I would call upon Dr. Manish Parikh to talk about embolic protection, review of available devices and evidence for use, including role of covered stents in vein graft interventions. Dr. Manish Parikh.
Good evening, and thank you again. It's been a lovely trip to Hyderabad. I want to again congratulate Dr. Srinivas, Dr. Kodali, and Dr. Leon for putting such a wonderful symposium together. So in the 10 to 15 minutes I have, and I don't want to keep anybody later than that, I want to review some of the important embolic protection devices for therapy for graft disease. I have no conflicts of interest. So clearly we have learned, and there's just as many coronary bypass grafting done here in India as there are abroad, that there is clearly, we know that there is early patency loss to vein grafts due to thrombosis and intimal hyperplasia, but what we know is that vein graft attrition is about 7% per year. And a lot of these saphenous vein grafts out at 10 years are going to either be diseased significantly or closed. And oftentimes you will not have much of a window of opportunity to treat these because once they thrombose, they thrombose. And the pathology of vein grafts is quite interesting. The disease process starts early because you have arterialized veins with first-month intimal hyperplasia that begins. And with time, there's buildup of atherosclerosis with superimposed thrombus. And clearly, with the occlusive thrombuses that we see in the occlusive disease, especially when we're treating these, it's really a lot like toothpaste. It's very, very rubbery and fibroatheromatous superimposed with thrombosis. So treating these, as you all know, is fraught with quite a bit of trouble. What we have noticed and know is that particles are retrieved in a large number of patients who we treat older saphenous vein grafts. And the particle size is dependent on, obviously, the size of the vein graft, the age of the vein graft, but a large number of particles between 17 to 60 microns is typically what we see in these patients. And so if we're able to prevent distal embolization, we're going to end up doing better for the patient. So what really occurs on a both macroscopic and microscopic level when you treat these patients? The distal embolization that occurs is caused by really microvascular plugging. And the plugging occurs not only with platelet aggregation and spasm, but you have thromboembolic disease and atheroembolic disease. Obviously, as I showed in the prior slide, the size of the particles varies, but it's really a four-pronged approach that causes the trouble. First and foremost, I think it's very important in vein graft disease, as part of your strategy of therapy, that in all these patients, you introduce some sort of intracoronary anti-vasospastic medications to prevent the spasm that occurs, not only at the macroscopic level, but at the microscopic level. And the way I would suggest doing that is instead of flushing it down the ostium of these grafts down the guide, often we don't get the medicine where you need, is to deliver it distally through end-hole catheters, distal catheter devices. And clearly, you could use a whole host of things, whatever you're comfortable with. In our particular cath lab, we like to use nipride. That's really our go-to. People say, well, what about hemodynamic instability? It's exceptionally transient, and I must say that nipride is the therapy of choice not only for spastic disease, but for no reflow in patients like this. Clearly, adenosine, verapamil, diltiazem, nicardipine all also work. The other thing I would say, and this is something that we try to teach all of our trainees and fellows, is that we always feel compelled, because of the large amount of thrombus in vein grafts when we see them in the acute settings, that there is very little benefit of 2B3A inhibitors. The data with 2B3A inhibitors in vein graft interventions is exceptionally poor and does not seem to have any clinical benefit, although you might use it when you see large filling defects. part of the problem that occurs downstream at the microscopic level is not really helped by 2B3A inhibition. So what do we worry about when we treat patients with venous graft disease? We really worry about myocardial necrosis. And the bottom line is that myocardial necrosis occurs in a lot of patients with vein graft disease, but it's the amount of CKMB release that you end up seeing, which is really going to determine your mortality, not only 1 year, but long term. In patients with major CKMB rises, greater than 2.5 times their baseline, clearly have shown adverse events with increased mortality. Moon Hong showed that a long time back, over a decade ago. In addition, no reflow in these patients is an independent predictor of in-hospital death and myocardial infarction post-PCI in these types of patients. So what are the therapeutic options that we have? Very simply, there are 3 groups: distal occlusive disease devices, distal filters, or proximal occlusion and flow reversal. The proximal occlusion and flow reversal I'm going to spend less time on because, quite honestly, the Proxys device is no longer being manufactured, unfortunately, and is actually not available on our shelves in the United States. So balloon occlusion devices were the first that were available. I think that it's something that it's mandatory to understand and learn how to use. And unless you use the PercuSurge device, you'll often forget and fumble how to use it when you need to. It's easy to use. It's easy to crush lesions with it. They're lower profile than our filters. They're compatible with all devices and guide sizes. They're completely occlusive. So not only are you going to block large particles, but you're going to occlude small particles as well. And that's the beauty of the distal balloon occlusive devices. And it is quite easy to use. The things that you worry about is that you have to work quickly because you're ischemic for the entire time of the balloon inflation. Patients will oftentimes, especially if they're LAD grafts, will be intolerant because of ischemia, so that can be an issue. You do need to have a landing zone distally. Sometimes you will see some injury with the occlusive balloon if the vein graft is quite diseased, and you'll have to deal with that as and when that happens. Here's the guard wire distal protection system. The application is very simple. You cross the lesion with the product through the guide. You find a safe landing zone distal. You occlude. You then test to make sure that you're occlusive, and then you go ahead and proceed with your procedure as you normally would. The key thing is that you must extract before you deflate your balloon, because all that debris is going to sit there in a swirl in the distal part of the lesion and the proximal part of the balloon. So the export catheter with aspiration usually does very, very well, and subsequently you will deflate the balloon and remove the entire system. So what data do we have in order to use this product? Clearly, in patients with significant vein graft disease, and I have to tell you that veins greater than 3 years of age, do not be fooled by how innocent they may look, because they will embolize and they will create significant infarcts. There was a 42% relative reduction in major adverse cardiovascular events with using protection. There was a decrease in the no reflow rate and a decrease in all myocardial infarctions with respect to not using protection devices in the SAFER trial. So some of the tips and tricks: 7 French system can usually help with backup. Prep carefully and do a dummy inflation out of the body to make sure the balloon inflates. If there's tortuosity, a buddy wire can sometimes help. Inflate at least 30 millimeters distal to the lesion, so you need to have a landing zone. Inflate at a location where the reference vessel diameter is steady. Test to verify that the graft is occluded. Work fast, but keep the device in a fixed position. In other words, you should not move this balloon around, because when you do, debris will go around it. And flush aspiration system and use of distal delivery with vasodilators as needed. The filter-based systems are much easier and friendlier, and most of us all know how to use them. Clearly, you will cross with either the filter product or the wire, depending on the filter you're going to use. You will then deploy the filter beyond the lesion and go ahead and proceed and treat the lesion. And oftentimes, if you get complete flow reduction, all that is telling you is one of two things. Either your basket was not big enough and you have no reflow, or your basket is completely full, in which case you need to aspirate before you retrieve your filter. The advantages are clearly it preserves antegrade flow. Contrast imaging is possible throughout the procedure, and it's a very simple process. The disadvantages, and again, it depends on the filter you utilize. You may not capture all debris, especially if you're not opposed in a orthogonal, nice round shape in a graft, especially in a very diseased graft. It'll be difficult to evaluate retrieval debris during the procedure. Filters may often clog, as I said, and sometimes retrieval sheaths may snag on stents, and this is a very important thing. If the sheath snags on a stent, you can often, if you pull it hard enough, actually separate the basket from its sheath. This is the types of extractions that you will get. It's not uncommon to get very large microscopic debris come out, toothpaste type material in the distal filters. This is the most common and first to be used by Boston Scientific. It's called the filter wire EZ system. It has a suspension arm which conforms to the curvature of the graft. It's got a very reasonable, soft nitinol wire tip at the end. It is a little bit bulky with 3.2 French profile, and it can also, it has actually a decent nose cone, but this is a device you actually have to work to cross tight lesions. What if the filter does not go through a tight proximal graft? There's several things you can do. You can use a buddy wire system. Sometimes you can gently predilate with a 1.5 balloon, but oftentimes you would say that that may defeat the purpose, in which case there are other options that are available on the shelf. The FIRE trial showed its randomized feasibility and safety for this. Along with the guard wire, there was a marked reduction in 30-day major adverse cardiovascular events. And clearly, there was a reduction in CKMB with both the guard wire and the filter wire system. This is my go-to distal protection device. It's the EV3 Spider. The reason I like this is that I could use any wire of my choice to wire the lesion. And I must say that it is much lower profile than the current filter wire. It comes in multiple sizes. It allows you to handle very big grafts. And actually, the pore size is very reasonable, and you get very good capture, and very often will not get complete occlusive of the basket. This is the SPIDER trial, primary endpoint, looking at MACE, myocardial infarction. Clearly, although not robust, it was non-inferior and trended towards an improvement. So the important things to remember, and I did not go over all of the available products that are out there. The important thing to remember is that you need to know the landing zone. The guard wire, you need a 2-centimeter landing zone. The FiberNet, which is only FDA approved for the carotid, also needs a 2-centimeter landing zone. The filter wire, you need a much longer landing zone. You may not have that landing zone in a vein graft, especially if the disease is in the distal part of the vein graft. The important thing to also know is that the crossing profiles are not low, okay? And so you may have to work these lesions to get these devices down, in which case the guard wire actually is a very reasonable thing to use, or the FiberNet once it becomes available. So tips and tricks for the distal filters. Again, I like to use 7 French for these vein graft cases. Prep and flush them thoroughly. Steering wire and devices on block. Deploy at least 30 millimeters distal to the lesion. Make sure you take orthogonal views of the filters to make sure that it's opposed. Keep it absolutely fixed during your intervention. Do not move the basket back and forth, because if you do, debris will go around it. And whatever you do, make sure that the filter or the basket does not come back to the stent, because if you do that, it will get entangled on a freshly implanted stent, and you're going to have a lot of trouble removing it from the patient. Now, having said that, what percentage of our vein grafts are actually eligible for the standard distal protection. And it turns out that it's not everybody. 20% are eligible for only proximal protection, 23% are ineligible for any kind of embolic protection, 18% are eligible for only distal protection, and 39% are eligible for either proximal or distal protection. And so there will be a rare circumstance, for instance, the standard distal anastomotic lesion, where you cannot use any protection device. I'm going to briefly go over the Proxis device because I think it's important, because it is going to come up, especially in those of you that are using carotid stenting. The reversal of antegrade flow is important, and this particular concept is important. The entire device sits proximal to the stenosis. You actually inflate the balloon so you have no flow in the graft you're working, so that there can be really no distal embolization because there's stagnation or no flow in the graft. You subsequently go ahead and treat through the balloon, through the system, and do what you typically would do with stenting. This is the way the system looks. It's quite simple. And you could treat anything but your most ostial of stenosis with the Proxis, which is where this thing used to shine. And what we do realize is that there is a reduction in no reflow and major adverse cardiovascular events, even using this particular device. So, of the three products I've talked about, balloon, filter, proximal occlusion, there's favorable characteristics for all. Clearly, we like to see what we're treating, and so the filter does have an advantage over that. However, the distal balloon has a lower crossing profile and steerability, and sometimes you might need to use that. Don't forget about distal balloon. I think it's still a very nice device if you have that available. Just like anywhere else, what about the cost of these products? What do these products cost? Especially in the US, it's about $1,200 US, not inexpensive. Are these cost effective? The bottom line is when you do the cost effective analysis, in old degenerated vein grafts that you're going to have to treat, and you're not going to reoperate these patients, by preventing myocardial necrosis and no reflow and big infarcts, you actually have a cost savings because of the diminished infarct and hospital stays. And David Crone has shown this very nicely back several years back. So the ACCHA PCI guidelines that have been updated even and passed in 2005 recommend distal embolic protection devices be used clinically when technically feasible in patients who are undergoing PCI for saphenous vein grafts. It's a class 1 level of evidence B indication. What we do know, however, and we see this in the United States all the time, despite people understand that it's the right thing to do for the patient, it's grossly underutilized. Matter of fact, to the point where it's utilized less than it's less utilized than it is utilized. It's less than 50%. And what we do see is large numbers of patients with slow flow, no reflow when you're not using it. And clearly, although it may not have acute mortality differences, these large myocardial infarctions clearly do have long-term prognostic implications. So in summary, the use of proximal distal protection devices clearly enhance the procedural safety and reduce 30-day major adverse cardiovascular events. Thank you very much.
Thank you, Dr. Manish, for a nice, elegant presentation of all the protection devices.